And this is box 4910 from the 5th edition. When to consult with the patient's physician when the patient has the following. Um, and this is a little bit from the same as from the slide in the last video, but type 1 or type 2 diabetes, determine their level of control, if they're well controlled, poorly controlled. Complications such as renal disease or cardiovascular disease, if they're dealing with some other comorbidity, prescribed insulin, lapses in good medical management, and indication for extensive periodontal or oral maxillofacial surgery. So if they need some extensive dental work or oral surgery, then a consultation should be made with the patient's physician. Oral assessments, common and poorly controlled diabetics. So these are things that would be common to see if your patient's blood glucose is typically very high and they're poorly controlled. The angular cheilitis, which is that kind of cracked red lesions in the corners of the mouth, that's usually caused by a candidiasis. Xerostomia, glossidynia, burning mouth, enlarged salivary glands, increased incidence of lichen planus, increased glucose in the saliva, so they may have more dental caries, thrush, or an increase in yeast infections anywhere in the body, but we'd see it in the mouth more obviously only. Periodontal disease, and then oral ulcers and slow wound healing. So these are all common in a poorly controlled diabetic. So the caries, the higher rate of caries is for, of course, because there's usually, there could be lots of snacking, that could be part of it, but also the increase of glucose in the saliva and the decreased salivary flow. So those are three very common reasons. So now we're looking at things like saliva substitutes, nutritional counseling, and a topical fluoride would be recommended. Most diabetics are best controlled in the morning, so typically morning appointments is what you would want to do. However, I've seen patients in the clinic who never were stable in the morning, and like 10 to 2 or something was their best time. So 2 hours after eating is oftentimes ideal because of their medication and how it peaks and everything. Dental hygiene care should not begin until the diabetic condition is controlled. So it is an individual thing, but generally speaking, morning appointments are better. Also, we don't want our patients to wait very long in the waiting room, especially if they're nervous already. We want them to be comfortable and to feel that we're attending to them in a way that makes them feel comfortable. In our clinic, obviously, our patients don't really wait, but remembering that in private practice, especially if you have a nervous patient, because stress can affect hyperglycemia. Brief appointments are oftentimes better. I know in our clinic our appointments are very long, but generally speaking, an hour to an hour and a half, especially if it's a poorly controlled diabetic patient, you don't want to stress them out with long appointments. And then patient or client education tips. I'm not going to read through this. This is from just copied from the textbook. This is just a really good bulleted information for what to emphasize with patients. And in summary, it's emphasizing their increased risk to periodontal disease, their increased risk to infection and their slower healing time, informing the patient about how there's that bidirectional relationship with the glycemic control and periodontal disease, teaching them about good oral hygiene, making sure that they understand it, and practicing some of that teach-back method, discuss the maintenance of the dentition for chewing healthy foods, and reducing those fermentable carbohydrates, sugary drinks, things like that, that they probably have a lot of understanding anyways because of their diabetic education from the diabetic specialists, who a lot of times they'll have counseling and stuff specifically for lifestyle and nutrition, things like that. And then stress, emphasize the individual diabetes may not tolerate dentures. So if they are struggling with oral health and they mention like, oh, I'm just going to get all my teeth taken out and have dentures, it's important to help them understand that oftentimes Patients that have diabetes oftentimes don't tolerate dentures very well because the oral environment has a lot of things that are already difficult for them to deal with, like the increased tissue inflammation and the xerostomia and things like that, the increase for candidiasis, all of these things oftentimes, and then like the rubbing of a denture creating a sore and the poor wound healing, all of these things oftentimes can cause even more issues for patients who have to have dentures and are diabetic patients. Stress meticulous daily oral biofilm removal to control oral disease and also to help control their diabetes. And oral health contributes significantly to long-term systemic health in patients. So it's stressing how good oral health contributes to long-term systemic health. And diagnosis and planning when diabetes is controlled. Obviously, we're going to emphasize our oral biofilm control, monitor their health status, monitor their nutrition and dietary analysis, recommend fluoride. They can have chlorhexidine, xylitol. I don't recommend chlorhexidine to just, anybody. It's usually very specific, but I think this is saying that it's okay for them to have chlorhexidine if it seems warranted. Saliva replacement therapy, frequency of maintenance intervals very oftentimes is more frequent than every 6 months. If it's very well controlled diabetic patient, then perhaps 4 months or something like that, or 6 months. But very often our patients with diabetes, we'll see them on a 3 to 4 month basis. Collaboration with the physician and the diabetic educator is the phrase I was trying to find earlier, to make sure that everybody's on the same page. You can help the diabetic educator see the aspects of oral health that are important and vice versa. So it's wonderful to have that interprofessional team. The short term, so documentation, sorry, I have like a frog in my throat. Evaluation and documentation. Well-controlled diabetic situation typically responds well to SRP. There is delayed healing at times, and this can indicate hyperglycemia. Frequent recare intervals and frequent monitoring of the A1C is recommended. And of course, the intervals should be tightened up or shortened up, especially if your patient is poorly controlled. And then carefully record all the data, treatment plans, and any treatment that was performed, any relevant information and recommendations given to the patient should all be put in the notes. We can never put enough in our notes, honestly. I know sometimes it seems repetitive, but our notes are what saves us if something goes awry and the patient has a complaint against us. So we can never put too much detailed information in a note. It's also important, I think, to educate the patient that in the short term, the response of periodontal maintenance in the probing depths and the bleeding and the attachment levels and all of that in patients with diabetes appears to be equivalent to the response seen to patients without diabetes. So in the short term, a lot of times we may see good responses after scaling and root planing. However, patients with poorly controlled diabetes have more rapid clinical attachment loss and compromised long-term responses. So if you're seeing a patient and you're about to do a big old expensive SRP, and then they're going to maybe even have some periodontal surgery, but their diabetes isn't really well controlled, it's so important for them to understand that long-term their prognosis is not great. And so they really need to play a part in that, or at least have a very good understanding of that and have that be well documented. So a little bit about hypoglycemia. That's if the blood sugar is at 70 or below, and a most common metabolic emergency for individuals with type 1 diabetes. They might have taken their insulin but not eaten. And then 10 to 20 grams of glucose is usually enough to reverse the process give them what they need, and then more severe cases, they'll go unconscious, and if that's true, they might need an IV of dextrose or an intramuscular injection, and we probably are going to be calling 911. Just seeing if my notes said anything else that I did not. So, here's some good information. So hypoglycemia signs and symptoms result from a lack of glucose in the brain and compensation by the nervous system. For the nervous system compensates for the lack of this, of the lack of the glucose to the brain. And then box 4913 has some information here. But signs to look for: shakiness, feeling of anxiety, heart palpitations, increased sweating, and hunger. Tremors, tachycardia, altered state of consciousness, lethargy, and then blood glucose levels of less than, well, one resource that I found said 70 below, another one said 60. And then an unconscious hypoglycemic patient, we call the EMS or call 911. So I don't know if anybody's ever felt mild hypoglycemia. I have many times. I do not like it. And even sometimes after I've eaten, it takes a very longer time than I think it should to recover. We have crackers and juice in that little, in the center of the clinic, in that covered area, over by where the blood glucose kits are, in that cupboard down below. That's where there should be crackers and juice. So just know where those are and give them to your patient if they're not feeling good, or they're not feeling weak or shaky or heart palpitations, anything like that. And then hyperglycemic ketoacidosis coma, 1% death rate, much lower than in years before, thank goodness. Infection is the most common precipitating factor. So if there's some kind of an uncontrolled infection in their body, then it's going to precipitate, and it could lead to this hyperglycemic ketoacidosis. Requires hospitalization. And then table 44-5 on page 829 to compare hypo and hyperglycemia. I am concerned that's in the 4th edition. That might not be in the 5th edition. So if you can't find that, I think it might be in the 4th edition. But here, what causes a diabetic coma? Severe hypoglycemia, severe low blood sugar, diabetic ketoacidosis, extremely high blood sugar, or diabetic hyperosmolar syndrome, which is severe dehydration combined with high blood sugar. Oh, for heaven's sakes. Diabetic death caused by hyperglycemic coma currently represents 1% of adults with type 1 diabetes and are higher among younger individuals. Prevention is the best treatment. However, emergency treatment requires hospitalization. Coma that results from an absolute lack of insulin is found in persons with acute onset type 1 diabetes, in whom diagnosis was unknown or delayed in the individual with known diabetes, who discontinued or decreased their insulin for whatever reason. Coma from a temporary lack of insulin may be caused by an infection or stressful situation in which there is an increase in the secretion of anti-insulin hormones. So if something is super stressful, then your body's almost working against you already don't have insulin, but now your body's pumping in anti-insulin hormones. So that can trigger this hyperglycemic coma. Cortisol is an example. And then infection is the most common precipitating factor, and it's present in more than 50% of persons that have this happen to them. So you can see it's like a young person who maybe doesn't take their insulin and they eat, or they've decided to adjust their own dosage or something like that. Typically it's, again, not paying attention to the really important parts of and managing your own condition. Talk about stressful. Type 1, especially lifelong, and there's nothing to do there's no cure. So it's really something that patients have to, and be, very on top of. And they usually are very well educated and oftentimes can teach us a thing or two about managing type 1 diabetes. All right, I hope that made sense. That's kind of a complicated topic, and it's also very important to what we do. So I hope that was a good explanation. Give me feedback if you have any suggestions anytime, since we're getting about a third of, are we about a third of the way? Or a fourth of the way? Anyways, being 4 weeks in, give me any suggestions on these videos. If you are feeling like you need something else in the recorded lecture, please let me know. And I'm happy to try to make accommodations for you guys so that you can learn this material as best you can. All right, see you next time.